Hello and welcome to this session. We are going to be talking today about fertility treatment and loss. And within this, there are kind of two sides to what we see regularly, and that is people having fertility treatment and then experiencing a loss after that fertility treatment. And the other side that we see is people having fertility treatment because of previous losses. And we're going to be exploring both of those topics today. So I'm going to hand you over to my colleague now, Cassie, and she's going to tell you a little bit more about herself and today's event.
Thank you, Hazel. Good morning. My name is Cassie Destino. I am the founder of IVF Support UAE, and I am also a certified fertility doula. I myself have had several IVFs in order to conceive my twin children. And I also had a miscarriage at 12 weeks after my first IVF. So this subject is quite near to my heart. It is something that I have had a lived experience with, and I work every day with members of our community who, like Hazel said, are either endeavoring to have children and having miscarriage after miscarriage or failure after failure, or they are coming to us because they've had these failures and are looking for ways to help increase their chances of becoming parents through some of the technology that is available in fertility treatments. So Hazel, I'd love to hear a little bit more about you and who you are.
Thank you, Kathy. So my name is Hazel Leonard. I'm a midwife and a fertility educator. I've supported so many families and so many women over the years through trying to conceive, through infertility, fertility treatments, and then obviously through pregnancy, and losses at all stages. Sadly, from a chemical pregnancy to a stillbirth or a loss at any stage. I myself have been through numerous rounds of fertility treatments to get my two babies, and they weren't all successful. So there's a loss within that as well, that you grieve the loss of your embryos, you grieve the loss of what could have been. So it's something that's very, very close to my heart, and it's something that I also work in every day. And I think it's so important to recognize loss with infertility treatment, because many people will go, oh, it just didn't work, and that's okay, just do it again. But actually, there's a lot of an emotional toll that is embedded in all of this. So yeah, that's about me.
Right. So joining us today is Luciano Nardo, who is the founder and the president of Now Fertility. Now Fertility is a global full-service fertility care provider with clinics in the Middle East, in Europe, and North Africa. Luciano has become a very important and trusted voice in fertility care here in the UAE, and I personally turn to him with questions and for support for my own clients and members, and I'm so grateful that he's joined us. Luciano, welcome. Thank you so much for joining us today.
Good morning. Thank you very much, Cassie. Thank you.
It's a pleasure to have you. Let's start with a really basic question. What are some of the more common causes of miscarriage?
The most common causes of pregnancy loss are genetic, followed by immunological causes and congenital abnormalities of the uterus. So these are the three main causes of pregnancy loss. In my 25 plus years experience as a gynecologist and fertility specialist, I can say that probably 80%, 85% of miscarriages occur because of a genetic problem in the embryo. And that is a very important factor when it comes to being able to recognize the problem and finding a solution. Immunological causes are also common, but not as common as genetic abnormalities. Probably they account for between 5 and 8% of causes of miscarriage. and the rest probably will be again between 5 and 10% congenital abnormalities of the uterus, which means the uterus is normal on the outside, but the inside may present some abnormalities that will stop the pregnancy continuing beyond initial implantation. However, we all have to be aware that in about 20% of cases, there might be multiple causes. And that's the reason why once we find one cause of miscarriage, so for instance, we assume or we find out that there is a genetic abnormality with the product of conception, at that point, we cannot just stop all the investigations because there might be another cause. Maybe that the same lady has a immune problem, or maybe that the same lady has a uterine septum, which is a congenital uterine of the uterus, congenital abnormalities of the uterus. So in about 1 in 5 cases, we see multiple causes of miscarriage.
Yeah, I think that's touching on the reasons why is a big topic of discussion, because that's one thing that many people focus on. Why did it happen? And the first thing that women will do is blame themselves, and they'll go, oh, you know, it's because I drank a cup of coffee, or it's because I went for a run. And looking at the genetics is not always the place that somebody's heads go to. So it's good to know the reasons why. If somebody has suffered a multiple pregnancy loss, Luciano, so they don't have they don't necessarily have a problem conceiving, but they're having problems maintaining that pregnancy. How can fertility investigations, fertility treatment, IVF, how could that be of benefit to them?
This is actually a very interesting question, and one that is often asked by patients, either in the context of a normal consultation or indeed in one of the many fertility forums we have now online. As a fertility specialist myself, I actually am against recommending IVF as a first step for those couples and those women that have experienced multiple pregnancies losses. Why? Because IVF is a shortcut to pregnancy, and the specific couple, the specific woman doesn't have a problem in conceiving. So embarking on IVF per se will just lead to possibly another miscarriage. So it is important not to consider IVF, and indeed not to label that patient as being infertile, because she's not infertile. The first step will be to investigate the female as well as the male partner, because we need to remember that there is a contribution from the sperm as well, and there is growing evidence to suggest that sperm DNA fragmentation, sperm abnormalities contribute to making an embryo abnormal. And in this day and age, we see that ladies approach the first pregnancy at an advanced maternal age, which means the eggs have less ability to repair any genetic abnormalities that may come from the sperm. And a growing body of evidence suggests that eggs can repair abnormalities brought into the embryo by the sperm, but the sperm cannot repair abnormalities in the eggs. So it is I think it's plausible to speculate that if you have an instance where the female partner is 37, 38, 39, and there is also a sperm abnormality, then it is more likely than not that the embryo is genetically abnormal, which may result in a pregnancy, but subsequently will be an unfortunate loss. So having or recommending IVF is not the solution. Whenever I see or I talk to couples that have experienced multiple pregnancy losses, the first thing is to understand, to listen to them, to understand what are the factors potentially contributing to pregnancy loss, at what stage have the pregnancies started, and also what stage of pregnancies have ended, and more importantly, what symptoms they've been experiencing. Because each pregnancy may be different, we need to determine if there is a pattern. Once we undertake all the investigations, and I will just give you now a brief example of something that actually has happened very recently with a patient consultant. But once we've done all the investigations, then we can recommend the appropriate course of action, which may well be IVF for genetic testing of the embryos, may be immune therapy if the woman has a high thyroid antibodies or has a thyroid dysfunction, may be antioxidant if the male partner has an increased percentage of sperm DNA fragmentation. It may be surgery if she has a full uterine septum. So IVF is one of the strategies to overcome pregnancy loss only if there is a genetic abnormality in the embryo, and that genetic abnormality can be not treated, but can be picked in embryos, so not transferred at the time of IVF. So IVF will help to genetically test the embryos, screen the embryos, and transfer only healthy embryos, which, as I said, is very important because about 80% of pregnancies may end up as a miscarriage because of genetic abnormalities. But I would certainly not recommend IVF as a way to overcome pregnancy loss. And let me just give you this a real patient scenario. One lady in London came to me. She experienced 5 pregnancy losses over a period of 2 years after having conceived naturally a child about 6 years ago, 5-6 years ago. And she came and say, I just been told by my gynecologist that I need IVF. And we said, no, you don't need IVF. We need to investigate. So we started investigation, and we listened to her. What happens in her cycle? What happened in her previous pregnancy? What symptoms she's experiencing every month? And she said, every month I have spotting before and after my period. I have lower subpubic pain. And I asked, did you have a cesarean section? She said, yes, I had a cesarean section when I was fully dilated because the labor didn't progress. Now, what she was saying and the symptoms she was experiencing and the signs she was describing are consistent with something called cesarean section scar defect, which is when the cesarean section scar opens up over time and fluid can accumulate within the cesarean section before and after the period. Hence why she's got spotting, because there is some residual blood stuck inside the cesarean section scar defect. She experiences pain because of the contractions, and that fluid and that blood debris is toxic. So we organized an ultrasound scan which showed her having a cesarean section scar defect. However, we told her this is not the only test we should do because you may have other factors. So we did a karyotype, a chromosome analysis, as part of the investigations on both her and her partner, actually husband. And we found out that she's a carrier of a chromosomal abnormality, which is again, responsible in 75% of cases of pregnancy losses. Okay. Now, of course, the fact she has a healthy baby, which is likely to be a carrier of the same abnormality. So she's got a boy, which I think 4 or 5, I can't remember now the age, conceived naturally, but she had 25% chances of having a pregnancy, which she did. She has 50% chances of a child home to be a carrier of the same genetic abnormality that she has. But in 75% of her pregnancies, so in the majority, she will lose the pregnancy because of the genetic abnormality. So this is an example where having found one cause, okay, doesn't stop you from investigating fully both patterns. Also, having this is the I think the main point, that having put this lady through surgery to repair the cesarean section of scar defect, which is possible, would have not given her a better chance of success because she still got the genetic abnormality in the background.
So, I mean, it really goes to show that when you are struggling to conceive or to carry a successful pregnancy, that seeking help is pretty important, because like Hazel was saying, I think people sort of have a feeling, oh, this isn't working because I did this thing. And there could just be things that you would never begin to know, to even think about or question. When would you recommend that somebody start seeking this care if they are having multiple pregnancy losses? I mean, should they come after their first miscarriage? Do you want to see people after a couple? When would you recommend that people start to seek care?
Because it's not really one size fits all, because everyone is different, and the circumstances are different, and of course the possible causes are different depending on age, depending on social background and exposure to chemical solvents, work environment. Depends also on family history. But generally, if a couple is experiencing or has experienced 3 consecutive pregnancy losses, then should be investigated. Equally, if a couple has experienced 3 failed IVF embryo transfer cycles where good quality blastocysts were transferred, they should be investigated. Okay, but this is a general good practice standard. If someone comes and say, I want to be investigated, but she is 39, time is of essence. I would not say, no, come back after 3 failed pregnancies, or come back after you have had another 2 miscarriages. You have to take into account multiple factors. And also, you have to listen to the patient, because sometimes the signs and the symptoms they give you are very, very important to help you make a decision whether she should be investigated or he should be investigated at an early stage.
I love the fact that you're focusing on investigation as a key, because professionally, I've supported many couples, and it does vary from doctor to doctor and protocols and where they are. Some of my clients are in the UK and they going through the NHS. Others are in the UAE and they can go directly and they can choose who they want to see. And it does vary. Like in the UK, you have to have had 2 losses before you can go. But it's really important that if I think people are having what we say red flags, but if they're noticing that something off, like you said, this lady was having issues with her cycle every month, maybe she didn't need to go through those 5 losses to have, before she had those investigations. She may have had 1 loss and had the investigations. I also love that you talk about male factor. It's something I campaign about all the time, and it's something that I experience personally. With not getting good quality embryos, and it just being a case of, well, let's just do it again and not investigating the male factor side of it. I think that's really, really important, and it's great that there's more research coming out about that. I've also had clients that maybe have had 1 or 2 losses, and emotionally and psychologically, they don't want to get pregnant again because they don't feel that they could lose another baby. Because for women and couples going through this, it's not, putting a number on the number of babies that they lose is very difficult, because they're like, I want answers now. I don't want to go through that again. But then that does come down to, access to care and finances and where they are, I suppose. But it's very reassuring that you're saying, you know, listen to them, you know, listen. If there's something that they're saying, you know, every month, you know, I have a really short phase between when I ovulate and when I get my period, and I think I've had these miscarriages. Well, that's telling us something. So having those investigations as early as they feel ready, or as early as their body's telling them that something isn't quite right, I think is a really important thing that you're saying, Luciano. One thing we were going to ask about as well is, I think you two have been silenced for some reason. One thing I was going to ask about, or me and Cassie wanted to ask you about, is the value of genetic testing of embryos. And how that can,
and what it is. I think there is a lot of confusion about what it is. I know I've seen people saying, you know, I don't want a child with autism, so I'm going to do genetic testing. So, you know, could you talk a little bit about what it is, what it can tell us, and what it can't tell us, and how you would use it, when you would use it?
Of course, yes. So genetic testing of embryos as part of an IVF cycle has become a very good option for many couples beyond having a fertility problem. 25 years ago, when I started working and I started attending one of the first and largest IVF clinics at Hammersmith Hospital in London, we only used to see patients that could not conceive. They had to have they were infertile. They were coming to have IVF, I remember very well, and they were having injections in the clinic. They were having blood tests twice a day in the clinic. They were having mostly perhaps ultrasound scans every other day, because we didn't know much. So we were experiencing difficulties in understanding the fertile or infertile population. But over the last 2 or nearly 3 decades, what we've seen is actually that probably 50% of couples we treat in clinic have a fertility problem. The rest, the remaining 50%, they don't have a fertility problem. Either they conceive and they lose the pregnancy, or they have an underlying genetic problem for which fertility is not an issue, but they need IVF to create healthy embryos, or many other instances where there is no really fertility problem. Now, genetic testing has improved over the last 2 decades. We are able to not just to biopsy one cell in the embryo, which is normally what happens when we do a biopsy of the embryo on day 2 or day 3 of development. But when we do a biopsy of a blastocyst, we're able to have a much clearer, much more precise, much better understanding of the genetic makeup of the embryo. So by doing a genetic testing on a blastocyst, we are really able to determine with about 99% accuracy the genetic makeup of that embryo. Whereas if you do a biopsy of an embryo day 2 or day 3, where we take only one cell out of 4, 5, 6 cells, might be that actually that cell, like other cells, would have gone through a process of repair over the course of embryo development. So in this day and age, most clinics, most physicians, most scientists would recommend to do an embryo biopsy at a stage of blastocyst. Now, once we've taken some cells, which is a very safe, very straightforward, and very sensitive and specific test. Once we've done a biopsy, and then we can determine the genetic makeup of that embryo based on the cells we've picked up from the embryo. And we can study the cells. Now, we can study the cells for the sex, if you want to determine the sex of the embryo, so we know if it's boy or girl. We can determine whether the number of chromosomes is normal or abnormal, and that is known as aneuploidies. So if the embryo has the correct number of chromosomes, then it's called euploid. If the embryo has an abnormal number of chromosomes, for instance, Down syndrome, there will be an excess of chromosome 21. So that is an aneuploid embryo. So there is a wrong number of chromosomes. But also the genetic testing will help us to understand if there are abnormalities in one specific chromosome. Okay, so for instance, thalassemia. Okay, you can test the embryo if there is thalassemia. So if the parents have a history of thalassemia, then you can test the embryo for thalassemia. Breast cancer, colon cancer, and many other genetic diseases, or diseases that have a genetic link, we can determine. Okay, and this is through something called pre-implantation genetic testing for monosomy, so which are abnormalities in one chromosome. Whereas when we test all the chromosomes, we do pre-implantation genetic testing for aneuploidies, which means we are going to exclude embryos that have the incorrect number of chromosomes. But also, we can do a genetic testing to find out if there are rearrangements within the chromosomes. And that is called pre-implantation genetic testing, S for sugar and R for Richard, which means part of one chromosome may have shifted into another chromosome. Okay, and this is an example of a very common cause of pregnancy losses. So the patient came to see me a few weeks ago that had a balanced translocation. She had exactly that issue where some of the genetic material in one arm of one of the chromosomes, okay, shifted onto another chromosome. Okay, and what was in that chromosome went in the, vice versa went in the other chromosome. That's the reason why it's called balanced. So she's got the correct number of chromosomes, she's got the correct length of the chromosomes, she's got everything perfect. If you look at the number of chromosomes and the shape of the chromosome, but the genetic material in one piece of chromosomes just shift with the genetic material in a different part of another chromosome. So when we do genetic testing on the embryo, we need to know why we are doing it. If we just want to look for the number of chromosomes, if we want to exclude a specific genetic abnormality, which may be carried by the father or the mother, or if we are investigating someone because they have history of multiple pregnancy losses. Okay, so in the instance of implantation failure after repeated IVF cycles, or in the context of pregnancy losses or multiple miscarriages, we normally do a karyotype, which is the chromosomes of both parents. And then we can do IVF with genetic testing. If one of the parents has an abnormality, so for instance, they have a translocation, then we will be testing the embryos using PGT-SR. If both parents are healthy, so they have non-genetic abnormalities, then we will be testing the embryos for PGT-A for aneuploidies, which means we're going to look if the embryos have the correct or incorrect number of chromosomes. And generally speaking, there are multiple chromosomes that can be affected when it comes to aneuploidies, so having more than one representative in the same cell. But the commonest one will be trisomy 13, trisomy 18, and trisomy 21. That will be responsible for Down syndrome, Edwards syndrome, and Patot syndrome. Why I'm mentioning this? Because when we do PGT-A for aneuploidies, we can either look at the total number of chromosomes, or we can look at 5 chromosomes. And the 5 chromosomes normally are looked, which in my experience makes no sense, because the cost is the same, the test is the same, the analysis is the same. Sometimes it very much depends either on the physician preference or on the laboratory. But if we were to test only for 5, then you will be testing for 13, 18, 21, X and Y. X and Y are the sex chromosomes, which of course are going to tell us if the embryo or embryos are female or male, but sometimes may also indicate some genetic abnormalities with the sex chromosomes.
So we can't see things, emotional imbalances, or we can look at some intellectual, but for people who are looking for, this has come up in my group a couple of times lately, things like autism, we can't look for that.
No, we can't. We can only look for genetic diseases for which we know there is a genetic background.
Yeah.
But autism, so there is no genetic test for autism. This is actually comes to me every week. Okay, every week we have about 10,000 contacts for fertility problems every month, and every week we have probably 4 or 5 requests about genetic testing for autism. This is worldwide. We can't test for autism. There's no genetic test for autism. However, we know that autism is more prevalent in male than female. Okay? And I would say probably 95% of couples that approach us and say, we have 2 children with autism, they will have 2 boys with autism. So they will be looking for having a girl to reduce the chance of having an autistic son. Okay, but there is no, at this point in time, a test that will exclude the transfer of an embryo that is positive for autism.
No, it's really sorry, my screen just split. No, I think that's a really important topic, because people want to do everything they can to have, in inverted commas, a healthy child. And it's also knowing that some things are inherited and some things are multifaceted, and they're, autism, we're learning more and more about it, but it can come later. It can be due to things at the end of pregnancy. It can be due to early infancy. So we're learning more about that, but it's good for people to understand what they can find out with testing embryos from such an embryo. A blastocyst would be 5 days after conception, right? So it's very, very early. It's not you're testing later on. I just wanted to kind of look at the flip side of IVF and loss, and focus a little bit on losses after an IVF, or after fertility treatment. So we know, for example, that the chance of having an ectopic is slightly more increased with IVF, but could you tell us a little bit more about what people could expect if they have fertility treatment? Are they more likely to have a miscarriage? What can we do to support conception early on through fertility treatment, and what does that look like?
There is no data to say, to show, to demonstrate, to tell professionals and patients that if they have fertility treatment, maybe IVF, maybe IUI, any fertility treatment, they will be exposed to an increased risk of pregnancy loss. However, you said, Hazel, that there is a slightly increased risk of ectopic pregnancy after IVF. But that increased risk is because with IVF, we treat women that have tubal problems. So there is an underlying factor, that is the tubal factor, as increasing the risk of ectopic pregnancy. Now, also with IVF, we treat women that are older. So they will have an increased risk of miscarriage, not because of the IVF, but because they have an underlying factor, which is their chronological age.
Yeah.
So we cannot just say IVF is responsible for ectopic or IVF is responsible for miscarriage. But again, that's the reason why I am always an advocate of no IVF. Although actually I do IVF, I've done IVF for 25 years, because we need to be sure that we are recommending IVF to the right patient population, and we are managing their expectations. Okay. Yesterday, one of my associates came and said, we have a lady, actually she's a lady in France, she's 62, and she's going to somewhere, to a clinic in Greece, to have ovarian rejuvenation. Okay. And she's contacted us because after the rejuvenation, she wants to have sperm donation. Okay. Of course, this is a case we'll never treat this lady. But the point is, I don't think that I don't have, I don't judge, but this is an example where even she was to conceive, even if a miracle happened, her chances of pregnancy loss will be very high, not because of IVF, but because of a chronological age, because of the risk factors.
Yeah, definitely. No, I think that's very important, managing expectations. And this is why.
Sorry, go on.
Sorry. No, so I was just saying, this is just why it's so important to give that information to people from the off, that they know what to expect and they know what their individual risk is in that process.
Yeah, I think that you and I, Hazel, have both seen in our work that for a lot of women and families, they think that an IVF is a sure thing. And well, we'll just try. And if we can't get pregnant, we'll just have an IVF and then we'll have a baby. And, a lot of what our work as educators is to say, listen, there are a million things that have to go right for this to be successful. And, chances are you aren't aware of 75% of what those things have to be. And it's great that there are these tools, and I'm so grateful. And I used these tools after my own miscarriage, after my IVF. If I had done some genetic testing after that, my first IVF, or with my first IVF, I likely would not have had the miscarriage that I had, but it wasn't brought up to me. It wasn't indicated for me. And I didn't even know that it was a thing. So when I went on to have future IVFs, I absolutely used genetic testing, and I, was able to rule out 75% of the embryos that I had that looked good, that, looking in the lab with the microscope said, this looks like a good one, but it turned out it wasn't. And, I was able to use that tool, but I wasn't made aware of it until I had the loss. I think that a lot of women are educating themselves a lot about this. As we know, this is an expensive treatment. So before people are spending the money, they're doing the research and they're trying to figure out what they need to know about, how to maximize their successes. But it sounds like there are more tools coming all the time. They're getting better. They're getting more sophisticated. We're finding more things, and we're able to intervene. So it sounds like that if you are experiencing multiple pregnancy loss, that there is hope for you. There are interventions, there are investigations, and things that you can try to have a better result for future cycles. And that's really that's a really positive part of this technology, I think.
Cassie, allow me to say that beyond the technology, beyond the physician expertise and your role as an educator and the good quality of services that all the clinics worldwide provide, there's still an element of responsibility and ownership by the patient. and by the couple. Couples who experience multiple pregnancies loss, they need to be aware that beyond everything we discussed until now, there's also the ability to control the habits, the ability to be healthy, to have a healthy nutrition, to have a balanced lifestyle, and to ensure that they are not just financially ready to embark on IVF, but they're also physically and emotionally ready to start this journey if they choose IVF, as well as physically and emotionally ready to cope with miscarriage. I personally believe that empowering the decision makers, the patients with the right information is important. So if they choose to have a good, healthy, balanced nutrition, if they take regular physical exercise, if they give up smoking, if they reduce alcohol intake, all these factors are very important. And again, no point if someone is a heavy smoker or drinks daily that comes to the clinic and say, please do IVF with genetic testing on my embryos, because you're not helping yourself.
Yeah.
I agree. I'm a big advocate for preparing for fertility treatment, and also sometimes what we see, and I'm sure you've seen, you both have seen the same, is that when people make those big changes in their life, it helps with spontaneous conception, or it helps not to need certain things. So yeah, I agree. I think empowerment and knowledge and giving people an element of control, because you don't have much control in this. So giving them the tools that they can, as much as they can feel part of this process, of this thing that's happening to their bodies.
Luciano, I want to thank you so much for your time this morning. Now Fertility is here in the UAE, and really globally. People can find you on social media. I have tagged you in posts about today's event. And I encourage people to reach out to you or to me, and I can put them in touch with you for investigating their options for fertility treatment. Thank you again for always being such a reliable partner for us in the Love Through Loss community, and we really do appreciate you. Thank you so much.
Thank you, Cassie. Thank you, Hazel. Thank you.
Thank
Have a good day. Thank you very much. Bye-bye.